Honorable Chairperson, my senior colleagues, juniors, everybody very good morning. So Dr. Noor Alam gave a task which really is not that really easy thing. Let me discuss the thing. So this is a 62-year-old male, diabetic, hypertensive, dyslipidemic, who had recently infarcted inferiorly and having post-MI angina. ECG showed inferior MI, echo showed inferior hypo, with EF 49% and blood reports are unremarkable. Okay, picture is not playing. Anyway, Dr. Nulam showed the picture, so I'll go for the discussion. How I'm going to approach? First of all, is the discussion about anatomy. The problem with the right correlation is the tight infarct related and should be treated first. However, this is a very straightforward dilatation and stenting of this artery, and I don't think it merits any discussion. The main problem here, which is worth discussing, is the LED tight plaque at the proximal mid LED junction associated with the D2 bifurcation. D1 is very small, so D2 is extremely important here. So the LED diagonal is LED itself is a very big artery which has gone beyond the apex and supplying the part of the posterior surface. Diagonal is also a big side branch supplying a large part of lateral surface, and this branch cannot be compromised in any way whatever I do. The bifurcation angle is about 30 to 40 degree. Anatomically, both main vessel and side branch has straight course, which is an advantage for whatever I do. The options. The first option is whether to go for a single strand strategy to LED and bail out diagonal if necessary. The second option is a pre-planned two-strand strategy. Either it could be decay crush, mini or nano crush, or Carluke technique. And at last of all, T-stenting, although the angle is not favorable for T-stent, so that's out of question. So my approach in this case, as for any bifurcation case, I'll try my best to do a single strand strategy. So we'll try for a single strand strategy first, where both LED and diagonal dilate both gently, individually, and double kissing, and take the balloons out, take a good angio, and analyze the condition of diagonal ostium, D2 ostium after initial POBA. If the diagonal is reasonably dilated and there is no dissection or plaque shift or carina shift, I'll keep the wire inside the diagonal and stent the LED. We'll take the diagonal wire out, rewire the diagonal through struts, do post-dilatation and good pot. And again, I'll study the condition of diagonal to see if the bailout is required or not and end the procedure here. However, these things need not be very straightforward all the time. All things will change if diagonal ostium is compromised after initial POBA. Then it will be a proper pre-planned two-strand strategy. Wires are already in LED and diagonal. My choice of procedure here will be a Carluke technique. Angle is very favorable. Procedure is relatively straightforward in the case. Wire is already in the LED and diagonal. I'll stent the side branch, the diagonal first, do a first pot, take the LED wire out, and then take the diagonal wire to cross it to the struts to the LED. Dilate the stent strut to give a good access to LED, stent the LED, and do a second pot, then wire the diagonal through the struts and do a double kissing followed by a final pot. This should give a very straightforward and good result. There is other choice here. This is a nano crush which can be done. Putting the wire both the LED diagonal, put a stent in the diagonal, keeping a little bit bottom edge of the stent in the LED, crush it with the balloon, then stent the LED, do a pot, cross the diagonal stent through the struts, do a double kissing and end the technique. It is also very straightforward in this angle. So my final conclusion that I'll try my level best to stick to a single strand strategy. However, in a 64-year-old diabetic, chances are high that the diagonal ostium is fibrotic and will not yield to POBA. Decision will depend after pre-dilation of the diagonal ostium. If a two-strand strategy is required, I'll go for the Carluke tech procedure. Thank you very much.